Okay, we're going to do a slide presentation on Chapter 9, and that is for pain. Hopefully it won't be painful. Margot McCaffrey gives us a definition of pain as whatever the person experiencing pain says it is, existing whenever the person says it does. Pain is one of the major reasons that people seek healthcare. Nurses have a central role in assessment and management for many people. It is a major problem that causes suffering and reduces quality of life. The financial impact of pain is staggering. In the United States, unrelieved pain and inadequate management of pain costs an estimated $560 to $635 billion each year in direct medical treatment costs and lost work productivity. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. There's a couple of different mechanisms for pain. Transduction is one. Transduction is noxious stimuli that causes cell damage with the release of sensitizing chemicals. And these chemicals are listed as prostaglandins, bradykinin, serotonin, substance P, and histamine. These substances activate nociceptors and lead to the generation of action potential. NSAIDs and corticosteroids alter either the local environment or sensitivity of the peripheral nociceptors, and these drugs can prevent transduction and initiation of an action potential. Local anesthetics and anti-seizure drugs stabilize the neuronal membranes and inactivate peripheral sodium channels to inhibit production of an impulse, so we can help reduce pain through those mechanisms. Transmission, there are three segments that are involved. It's transmission along the peripheral nerve fiber to the spinal cord, and the dorsal horn, which is a processing portion of it, and then transmission to the thalamus and the cerebral cortex. So as the nerve carries pain impulses along the spinal cord, we can use sodium channel blockers that help block the pain. Okay. Perception occurs when pain is recognized, defined, and assigned meaning. There is no single precise location where pain perception occurs. Instead, pain perception involves several brain structures. For example, it's believed that the reticular activating system is responsible for warning the individual to attend to the pain stimuli. Cortical structures also are thought to be crucial to constructing the meaning of the pain. Behavioral strategies such as distraction, relaxation, and strategies are effective pain reduction therapies for many people. And we'll talk about that in a little bit. And then opioids and other classes of analgesics, such as some types of anti-seizure drugs and antidepressants, modify pain perception. Modulation is the activation of descending pathways that exert inhibitory or facilitatory effects on the transmission of the pain. So these are the descending modulatory fibers that release chemicals such as serotonin, norepinephrine, those things that are called GABA, and endogenous opioids that can inhibit pain transmission. Several antidepressants exert their effects through the modulatory system. For example, amitriptyline, which is Elavil, Effexor, and Cymbalta, and these are used in the management of chronic non-malignant and cancer pain. Nociception is the physiologic process that communicates tissue damage to the central nervous system. And this is a four-step or a four-process transduction, transmission, perception, and modulation. And here's a pretty little picture that I left in for you. I believe this is in your book. So there are two underlying pathologies, nociception and neuropathic. Nociception is damage to somatic or visceral tissue. A surgical incision, a broken bone, or arthritis. These are usually, they respond to things like opioids and non-opioid medication. Neuropathic is damage to peripheral or central nervous, peripheral nerves or central nervous system. These can be described as numbing, hot, burning, shooting, stabbing, or electrical in nature. They can also be described as sudden, intense, short-lived, or lingering, and causes can be trauma, inflammation, diabetes mellitus, infections of the nervous system, tumors, toxins, neurologic diseases. They're not controlled well by opioids alone. They can be augmented with other drugs such as the tricyclic antidepressants. So one of the things that we do with patients like diabetic patients is use combinations of drugs. So we might use an opioid to help control pain and then also put in another drug like Elavil. And Elavil is a drug of choice to combine with a pain medication for a diabetic. When they complain about diabetic neuropathy pain, we will put maybe a Tylenol number 3 and then give them Elavil along with that. So that's something to remember. You might see that sometime soon. We also classify pain by duration. We can have acute pain, and that is usually sudden onset, lasts less than 3 months. We expect sudden pain or acute pain to resolve. It decreases over time and goes away as recovery occurs. It includes post-operative pain, labor and trauma pain. The treatment goal of pain control with eventual elimination. Some of the symptoms that we expect to see with acute pain might be an increase in heart rate, respiratory rate, and blood pressure. With chronic pain, some causes would be persistent pain. We could see this as either gradual or sudden onset. It could be acute pain that goes into a long-term duration, and the recovery time is unknown. The cause may be unknown. It's pain that does not go away. It can be characterized by periods of waxing and waning. It can be characterized by decreased physical movement and activity and fatigue. We can also see people that withdraw from others in social interaction. It can be disabling, and it can be accompanied by anxiety and depression. So the treatment goals for this are to control the existing extent when possible, and focus on functioning and getting people to a better quality of life. Fibromyalgia is one of those diseases that causes chronic pain. When we have a patient with a disease like fibromyalgia, we don't necessarily focus on pain relief. More, we focus on goals. So instead of talking to a fibromyalgia patient about we're going to relieve your pain, we talk to them about we're going to help you get to a point where you can run the vacuum, or where you can go to the grocery store, or where you can set a goal to play 8 holes of golf. Something goal setting rather for activities rather than controlling pain. That's different than setting a goal or looking at a patient that's 2 days post-op, and finding them in pain and where they might be showing us confusion, poor cough effort, shallow breathing, and an elevated heart rate because they're in pain. That's acute pain. We can fix that by giving them pain medication. We would recognize those signs and symptoms and medicate them with a pain medication. So those are two different processes there. When we do a pain assessment, we look for a couple of things. We look for a pain pattern. And we may actually mark this out over a day, over several days, over a week. There are some pain medications that are given long-term, maybe a Dirksen patch that's given over 3 days that's changed every day. At that point, we would look for breakthrough pain. So if you're putting on a patch that's a 3-day dose and the patient has breakthrough pain at 2.5 days, then we would need to alter the schedule. We also need to talk about what pain medication can be given for breakthrough pain. We also look at pain location. We look at intensity. We look at the quality of the pain. Are we treating the right pain? And we look at associated symptoms. So those are all things that we consider when we do a pain assessment. This chart I left in because it shows areas of referred pain. I believe this is in your book. It's kind of interesting. I think everybody associates heart pain with left arm pain, jaw pain, and this illustrates that. There's also other areas listed on here that dictate associated areas of pain. When we talk about pain management and treatment principles, our goal is for management, we strategize or use strategies that include prescription and non-prescription drugs, non-drug therapies such as hot and cold applications, and complementary and alternative therapies such as herbal products, acupuncture, relaxation strategies, and imagery. We follow the principles of assessment. We also look at every patient and know that they deserve adequate pain management. We look at patient and family beliefs, their attitudes, their culture, and their expectations. And that influences the way they respond to pain and pain treatment. We look at we expect about their expectations and goals for pain management. So we know that the patient and the patient family are part of pain management altogether. Documentation is critical to ensure effective communication pain assessment tool. We use a multidimensional pain assessment tools, and your facility will probably have something specific for this. We need to make sure that we establish a baseline for the patient. Many healthcare facilities and agencies have adopted specific tools to record an initial pain assessment, treatment, and reassessment. Reassessment is just as important. It's critical to reassess at appropriate intervals guided by the pain severity, the physical and psychosocial condition, the type of intervention, the risk and adverse effects, and the institutional policy. So, for example, a postoperative patient is reassessed within 30 minutes of an IV dose of analgesia. That's on the floor. If it's a post-op patient that's just back from PACU, their reassessment is going to be every 5 to 15 minutes. If this patient or a patient is in a long-term care facility, their reassessment may be done over a period of hours to days to weeks. It may also be done on rather in a change of condition or a change of functional status. So it's based on, so it can be based on several different situations. It just depends on the institutional policy and the setting. Pain treatment principles, we follow the principles of pain assessment. We use a holistic approach. Every patient deserves adequate pain management. We base treatment plan on the patient's goals, and every patient may have different goals. We use both drug and non-drug therapies. We use a multimodal approach when appropriate. We address pain using an interdisciplinary approach, and we prevent and or manage medication side effects. We incorporate patient and caregiver teaching throughout because we are teachers. Only the patient can be the best judge of his or her own pain. We need to help the patient set a realistic goal for pain relief. And we do that through conversation. Sometimes we do that with family at the bedside too. Some of the pain services, when I talk about multimodal and interdisciplinary approaches, some of the pain services that can be included are things like massage therapy, music therapy, acupuncture, art therapy, and we'll talk later about managing medication side effects. There are 3 categories of medications that we use. We use non-opioid, opioid, and then adjunct therapies. So let's look at those. Non-opioids are things that you probably already know. They have an analgesic ceiling. So the efficacy is not going to increase above the upper or the top dosing limit. So the old adage of if I take 2, that's good. If I take 3, that must be better. That's not going to help. There's no reason to go over the top limit. It's important to know that most of these are going to be over-the-counter medications. So patients need to be truthful in what they're actually taking. They do not produce a tolerance or an addiction. And many times we use these in combination drugs. So you might see a non-opioid in combination with an opioid, like a Tylenol number 3 or a Percocet or a Lortab. You know these as aspirin or other salicylates, acetaminophen, and NSAIDs. Aspirin is effective for mild pain. It's limited by its side effects. Its risk for bleeding, especially GI bleeding. Acetaminophen or Tylenol has an analgesic and an antipyretic effect, but no antiplatelet or anti-inflammatory effect. It is metabolized by the liver, and the FDA has put some limitations on what we can give in one day because of this. It does have some hepatotoxicity properties, so we do limit that, or they do. NSAIDs are a broad class of drugs with varying efficacy and side effects. Let's see, the action of NSAIDs, and ibuprofen is an NSAID, decreases the production of pain-sensitizing chemicals. Let me say that again because that's important for you to know. The action of NSAIDs, and ibuprofen is an NSAID, it decreases the production of pain-sensitizing chemicals. Okay, some NSAIDs are equal to aspirin. Others have better efficacy. Side effects include GI problems, renal insufficiency, and hypertension. Patients vary greatly in their responses to specific NSAIDs. So when one NSAID does not provide relief, another should be tried. NSAIDs are associated with many side effects, including GI problems, ranging from dyspepsia to life-threatening ulceration and hemorrhage. Renal insufficiency and hypertension also occur. If an NSAID is used in patients at risk for GI bleeding, they should have concomitant therapy with a proton pump inhibitor such as Prilosec. NSAIDs should not be administered concurrently with aspirin, as they are a risk for bleeding and GI adverse effects are increased. Okay, opioids. Our friends opioids bind to the receptors in the central nervous system. They inhibit the transmission of the nociceptive input. They alter the limbic activity, and they activate the descending inhibitory pathways. We have a couple of different kinds. The pure agonists are the ones we use most often. These are morphine, oxycodone, and codeine. Opioid agonists are used for both acute and chronic pain. They're used to treat both nociceptive and neuropathic pain. Pure opioid agonists include morphine, oxycodone, hydrocodone, codeine, methadone, hydromorphone, which is dilaudid. We don't use that a lot anymore. And morphine, and this is important for you to know, can cause respiratory distress. So let me say that one again. Morphine can cause respiratory distress. And let me give you a scenario. So you had a post-op patient that came to your floor. Let's say we're 2 hours post-op. They spent an hour in PACU. They've been with you an hour. You've given them some morphine, and you went in to assess them. And they're not easy to arouse. They look fairly comfortable, but they're not easy to arouse. You do a set of vital signs, and they're breathing at 10 a minute. Does that concern you? Think about your normal respiratory rate. I like my patients to be breathing about 20 breaths a minute. I don't know about you, but 10 a minute concerns me, especially when they're fairly sedate. Yes, they're comfortable, but they're a little too comfortable. So 10 a minute, and knowing that they've had morphine bothers me, because I know that morphine causes respiratory depression. So that could be problematic. This is something that you would either call a rapid response for. You would slap an O2 sensor on their finger and see what their saturation is. You'd bring your charge nurse in, or you would do an intervention for this one. This is not a good thing. Okay, combined with non-opioids for moderate pain. So we would see codeine with acetaminophen, and this increases the efficacy of the opioids, so we can use less. Tylenol number 3, Vicodin, Vicoprofen. Methadone is a unique mu opioid receptor agonist. It is relatively short acting analgesic. When it's first administered, it's 4 to 6 hours. And then after 3 to 4 days, its half-life builds up and lasts 90 to 120 days. We have mixed agonists and antagonists, and those are now Buchen, and I'm not going to even try to pronounce the rest of these. You can read them. We also have mixed mu agonists and opioids and dual mechanism agents. And tramadol is one that you might know. Ultram is another name for it. And we use these for back pain and osteoarthritis and fibromyalgia. Again, combination drugs. Some of the common side effects with opioids: constipation, and this is the most common. Nausea and vomiting, sedation, respiratory distress, and pruritus. So with continued use, many side effects can be diminished. The exception is constipation. And if you get a chance to watch TV, there is a very a commercial out, and I even forget the name of the drug it is, but it's for opioid-induced constipation that is all over the television right now. So anybody that is on an opioid for long-term pain management needs to be on some kind of a bowel regimen to prevent this. Most patients should be using a gentle stimulant, laxative, and a stool softener. Nausea often is a problem in opioid-naive patients if they don't use them routinely. So for these patients, especially patients that are using a sustained release morphine sulfate like MS Contin, they can have side effects of constipation. So if one of them comes to you and complains of nausea and vomiting and abdominal fullness, we can medicate them with an antiemetic medication. So nausea, vomiting, and abdominal fullness can mean that we should treat them with antiemetics. Okay, adjunctive therapy. We can use, in conjunction with opioids and non-opioids, we can generally use other types of drugs that help. And so some of these drugs are corticosteroids. They enhance the opioids. We also use antidepressants, like the tricyclic antidepressants. We can also use anti-seizure drugs. Lyrica is one. I think there's TV commercials for Lyrica. And then GABA receptors are another drug that we can use. And then, and these are used in combination with opioids. We can also use alpha adrenergic agonists. We can use local anesthetics. We can use the mixed mu agonists. And then I want to call attention to the last one, cannabinoids, I guess it is, because this has been in the news lately. And we've been seeing some progress, at least I think it's progress over the last probably 10 years, about making cannabinoids legal for medical use. I think for medical use, there's a lot of research that needs to go on, because there is some very good properties that go along with cannabis. Whether you're a recreational smoker or not is, I don't care. But the drugs that come from that product have medical qualities that need to be explored and have some value. So smoking marijuana or cannabis rapidly increases the plasma levels of THC, and this has helped a lot of people. So it's up here because of that. All right, administration. We talk about scheduling. We focus on prevention or control. We do not wait for severe pain. Constant pain requires around-the-clock administration, not PRN administration. If we have a breakthrough, we look for a fast-acting drug, and that's part of scheduling. Titrating a dose. It's based on the assessment of the analgesic effects versus the side effects. If it's an acute pain management problem, we expect titration to be faster. If it's a chronic pain, titration will be a little bit less. We use the smallest dose to provide effective pain control with the fewest side effects. Oral administration routes. Oral is the route of choice if you have a functioning GI tract. We can also use a transmucosal and buccal route. And some of those would be fentanyl lozenges on a stick or cannabinoid extract sprays. We have intranasal spray, getting to a very vascular mucosa. We can use a rectal approach. That's also a very mucosal area that if someone is not able to keep something down because of nausea and vomiting, you can use rectal or even vaginal for that matter. Transdermal is you can put a transdermal patch on a non-hairy skin, or you can put it on hairy skin and pull it off, and then it's non-hairy. Either way works. Parenteral routes, we have IM, subcutaneous, and IV. We have intraspinal delivery, and this is very high potency, so you use smaller dosages, and make sure that you're checking your drugs so that you don't get an intraspinal dosage in your IV, because that can kill. There's special training that goes along with intraspinal delivery. You can have implantable pumps, and these are long-term, that are usually filled based on a weekly basis or as needed, and then patient-controlled analgesia. So for a cancer patient that complains of a deep ache, say an 8 on a 10 scale, IV hydromorphone is the best drug, not a patch, not a tablet, or a suppository. And why would that be? Why would we want to give an IV drug rather than a patch, a tablet, or a suppository? Because IV is the fastest acting route. Of all of these, IV, interspinal would be too, but IV is the fastest acting route. And a pain of 8 on a scale of 1 to 10 is a high or a severe pain, so we would go with the fastest acting route. Nerve blocks are another route. We usually use those in surgery in lieu of a general anesthesia. We have also neuroablative techniques, and these are long-term techniques, and they just basically go in and obliterate groups of nerves that are constantly firing and causing pain. So this stops the nerve transmission. And then we have neuroaugmentation, which would be an inner stem, which is like a pacemaker. It's a pulse generator that overrides an electrical stimulation or provides a stimulation to the brain and the spinal cord. And these are commonly used for chronic back pain. There's other purposes, but that's one purpose for them. Nondrug therapy. These are therapies that increase the patient's sense of personal control about managing pain and bolstering coping skills. It reduces analgesics and requires and minimizes the side effects. So some of the non-drug therapies that we can use are massage, exercise, TENS, and that's transcutaneous electrical nerve stimulation. And some of these have actually, I've seen advertised as over-the-counter now. Acupuncture, and there is an acupuncture place downtown Nashville, I've heard, and hot and cold therapy. Some of the cognitive therapies that we use, distraction therapy. It involves redirection of attention away from the pain onto something else, hypnosis, so that this alters the patient's pain perception, and then relaxation strategies. So what's important for you to know is that imagery and hypnosis helps control pain by affecting the patient's perception of pain. So a patient can help themselves or help themselves by altering their own perception, and they can use imagery and hypnosis. Imagery and hypnosis. Effective communication is one thing that we are charged with as nurses. We are important members of the interdisciplinary pain management team, and we provide input into the assessment and reassessment of pain. We help in planning and implementing treatments, including education, advocacy, and support of the patient and the family. Patient's report of pain is believed and not perceived as complaining. And that is a stigma that's in society today. And I have to say that I can be guilty of that. The nurse communicates concern and affirms commitment to the patient, together with the patient developing a written agreement or treatment plan that describes the pain management, the The plan should ensure that the pain will be treated based on the patient's perception and report of pain. In addition, the plan should clearly outline the gradual tapering of the analgesic dose with eventual substitution of parenteral analgesics with long-acting oral preparations and possibly cessation of opioids. And I have to add here that this is not necessarily a plan that is achieved in an acute care setting. This is something that we may set up in an acute care setting with the knowledge that it will play out over a period of time. Common concerns about effective pain management is that the patient will build up a tolerance to a variety of drugs, that they will build up a physical dependency, and there are physiological responses to ongoing exposure of pharmacological agents that are manifested by withdrawal syndrome, that there can be a pseudo-addiction, and this is caused when the patient exhibits behaviors that look like they're seeking drugs when really they're seeking pain relief because their pain relief has not been adequate. And then there's true addiction, which is a complex neurobiologic condition that's characterized by aberrant behaviors arising from a drive to obtain and take substances for reasons other than prescribed therapeutic value. In other words, they're not seeking drugs for pain relief. They're seeking drugs for other types of relief. Addiction rarely occurs to patients who receive opioids for pain control. Barriers to effective pain management, inadequate healthcare provider education, and we're trying to be better at this. Over the past decade, progress has been made in overcoming these barriers. Medical and nursing schools now devote more time to addressing pain. Numerous professional organizations have published evidence-based guidelines for assessing and managing pain in many patient populations and clinical settings. We are getting better. Some of the ethical issues that go along with pain management is fear of hastening death by administering analgesics. There's been no scientific evidence that opioids can hasten death, even among patients that are at the very end of death. You have a moral obligation as a nurse to provide comfort and pain relief at the end of life. Unrelieved pain is one of the reasons that patients make requests for assisted suicide. Aggressive and adequate pain management may decrease the number of such requests. Assisted suicide is a complex issue that extends beyond pain and pain management. The use of placebos in pain assessment and treatment is unethical. Using a placebo involves deceiving patients by making them believe they are receiving an analgesic, usually an opioid, when in fact they are getting some kind of an inert substance such as saline. The use of a placebo to assess or treat pain is condemned by several professional organizations. And so let me stop and make a personal statement here. You've heard me talk about my mother many times. My mother is a chronic pain patient. She's had fibromyalgia for many, many years. In the 1960s, she went to Barnes Hospital for a surgery. She got into a situation where she had a very low blood pressure, was in extreme pain, asked for pain medication, and was given an injection. Her pain was unrelieved. A nurse told her the next day that she never received pain medication. She received a placebo shot. From that day forward, she has never believed that whenever she's gotten something for pain, it's been a true medication. In her mind, she's always gotten a shot of saline. That's one of the side effects of using placebo injections. So it's unethical to do something like that. It has lasting effects. So don't do it. Now, here is a situation that I want to give you. Let's give you a scenario of a patient that is a hospice patient They're complaining of severe pain, so let's define severe pain. 8 on a scale of 1 to 10. You assess them, and remember, they've complained about this pain. You assess them, their respiratory rate is 10. What do? Let's go back to the scenario of the post-surgical patient. 2 hours post-surgical, you've done an assessment on the patient that is slow to arouse, and they're breathing 10 a minute. This is a little different situation. You've got a post-surgical patient over here that's breathing 10 a minute, slow to arouse. Over here, you've got a hospice patient that is sitting there telling you, I have pain, and they're only breathing 10 an hour. 2 completely different situations. Your hospice patient, you want to medicate until they get adequate pain relief. Hospice means they are at the end of their life for whatever reasons. They deserve to have adequate pain control. The fact that they are awake and alert and telling you that they are in pain tells you that they are breathing adequately. Over here, in our post-surgical patient, this patient is drowsy, slow to respond, slow to awake. You've given them morphine previously. They are not. They don't need any more morphine. They need some help. That's a completely different situation. Over here in hospice, we need to medicate these patients until they are getting adequate pain relief. Even if it is with morphine, if that's what's been ordered for them, it's okay. So 2 completely different situations. Okay, chronic pain is a problem associated with physical disability and psychosocial problems. The prevalence of chronic pain among community-dwelling older adults exceeds 50% among elderly nursing home patients, and among elderly nursing home patients is approximately 80%. And I would believe that. And we've stepped over here into the gerontological consideration. So other considerations with chronic pain comes with depression, sleep disturbance, decreased mobility, decreased healthcare utilization, and physical and social role dysfunction. Most common painful conditions include musculoskeletal, osteoarthritis, low back pain, old fracture sites. And I think if you stop a minute and think about people that you know, whether they're friends or family, and think about age, and you can probably come up with a person or 2 that might fit into these categories. Chronic pain has some long-term effects that can be eased with pain management. Some of the barriers with our elders is the belief that pain is inevitable for aging. That's not necessarily so. There's a great fear of using opioids. Yes, there is, but there are other things that we can use. Our elders don't like to use the word pain. They might describe their pain as aching, soreness, or discomfort instead. Those are still describing pain. There's also a high prevalence of cognitive, sensory, and perceptual and motor problems. So as we talked last week, with gerontological considerations, there's also hearing and visual deficits that can complicate the issues. It goes right along with the cognitive impairments. If you don't see well, you don't hear well. How do I know what you're telling me is true? It's a cycle. It's a vicious cycle. Pain assessment tools may have to be adapted for our elders. And remember, you're going to be an elder one of these days, so we want these tools to be accurate. Treatment cautions. Elders metabolize drugs more slowly. There is a risk of GI bleeding with NSAIDs. There's lots of teaching that goes along with this. There's also the risk of multiple drug or polydrug interactions. The older you are, you might have more disease processes going on, so we have to watch out for all the things that could be mixing up with the drugs you use. There's also cognitive impairments, ataxia, that can exacerbate the use of analgesia. Many illnesses and conditions affect a patient's ability to report pain. The older you get, the more likely you are to have some of these conditions, things like Parkinson's, multiple sclerosis, cerebral vascular disease, CVAs, psychosis, delirium. We have scales to assess pain in cognitively impaired, and they're based on common behavioral indicators, things like facial expressions, breathing, body movement, or tension. Be aware of those. Assessing and providing relief with a dual diagnosis of pain and substance abuse are challenging. So these are stepping into our special populations. Healthcare providers are often reluctant to administer opioids to substance abusing patients for fear of promoting or enhancing addiction. There is no evidence that providing opioid analgesics to these patients in any way worsens their addictive disease. In fact, the stress of unrelieved pain may contribute to a relapse in the recovering patient or increased drug use in the patient who is actively using or abusing drugs. These patients still have a right to receive effective pain management. It's been my experience that recovered addicts will tell me, no, I don't want a narcotic or an opioid. I want an NSAID or I want something else. They will very reluctantly or refuse totally any kind of an addictive type substance. But with that said, they still have the right to adequate pain management and pain control. With substance abuse problems, we still have to do a comprehensive pain assessment. These patients still deserve a detailed history, a physical examination, a psychosocial assessment, and a diagnostic workup. Whether they're recovered or they're still actively addictive, they are still a patient, they still have needs, we still do these things. We still establish a treatment plan that will relieve pain and minimize withdrawal symptoms. Usually this requires a multidisciplinary team approach. When possible, the team should include pain management and addiction specialist. And with that, we are at the end of the lecture. And that is the end of chapter 9. Thank you.